So tell me, when did the light bulb go off? What made it go off? Why did you all of a sudden say, I'm going to head down this path?
Yeah, that's a great question. So you got to remember this was, late 90s. And talking to George said at the time that if he was residency, he would not go into arthroplasty. There was nothing left to discover. Nothing left to do. He would do spine because there was a lot to do in there, but there was nothing left in our arthroplasty. So I was trying to prove him wrong. So I looked around. We did so much work in prosthetic design, materials, all of these things. No one had touched or really thought much about touching how the surgery was actually done. So I thought, at the time, like most people did, that the soft tissue that we buggered up, maybe was 10, 20% of the pain they had, but the majority was from the cutting the bone, putting the implant in. And everyone told me this was a fool's errand. It's only 10 or 20%, but I'm like, look, 10 or 20% is better than nothing. Why don't I head down this path and see what happened? So I spent 2 years doing cadaver work and developing implants. Zimmer was nice enough to help me. Yep. And this was way before anything happened with the FDA, but I would sketch out little things, fax it to them because there wasn't internet, right? Fax it to them, and I would have a piece of metal in my hand the next day.
That was when you
next day.
You could innovate so fast.
So I could play with things in the cadaver lab, take it to the OR, find it, and develop this minimally invasive surgery technique. And started with hips. And the first case, took me 4 hours to do because I wasn't really know what I was doing. I did it with an IRB, so everything was studied. Patients knew. Was
this the 2 incision that we started?
This was the 2 incision, yeah.
Because you've heard this. I was your assistant on 12 of the first 20.
I know.
I remember. I don't know which one it was where you, but I remember a 4-hour plus one.
That was probably the first one.
Muscular
That was probably
male.
the first one. Yeah, I was stupid at the time. So, but I did. I'm
glad we shared that moment together, by the way.
We bonded over trauma.
Yeah, that's exactly right.
So we did. So I started off doing this, and pretty quickly got good at doing the surgery. Every patient knew that there was part of a study protocol. The first patient, who was a lawyer, by the way, I don't know what I was thinking. First patient was a lawyer.
Prosecuting.
It worked out fine, but they wanted to be number one, and so. Lo and behold, patients started to get better, not a little quicker, not 10 to 20.
And back then, they were in the hospital
7 to 10 days. And in fact, George's hip replacements, I remember, were in balanced suspension for the first day or two. Balanced suspension for the first day or two.
I remember the rounding. And
right.
I'm as a resident, you're just like managing fleets of patients there forever.
Right.
It's brutal.
So these patients, not 10 or 20% better, but dramatically better. And they got up, and they would get up right away and start walking around and why are we in the hospital? And I'm like, I don't know. So we started letting them go, on day 2, day 3. And then I had a couple patients. We did it in the morning. I had a couple patients who said, well, why am I in the hospital? I'm like, well, we can't send you home. That's crazy.
Right, that's crazy.
That's crazy. So I started thinking about doing outpatient joints. But there was so many other things that had to change because we were doing general anesthesia with tons of medication. Patients felt nauseated. They got hypertension. So I went to the anesthesiologist and said, who would like to help me? And of course, no one would. So I went to a fantastic anesthesiologist we had. Her name was Heather Nath. And brand new. You remember Heather?
Oh, yeah.
She was fantastic. And she was brand new. And she said, of course I'll help. And I said, well, okay, forget I'm doing hip replacement. Let's pretend I'm doing an ACL. What would you do for anesthesia? She's like, oh, I wouldn't do any of this stuff. I do this stuff. Well, let's try this stuff. Right. So we went from general to regional, from a ton of medications to very little medications, and patients just felt better. So that's when I started doing the outpatient protocol and played with all that stuff and really worked on it from so many different angles. Everything had to change because the patient would come in the hospital and the admission person would say, you're not going home today. What are you talking about? You're having a hip replacement. You're staying a week and a half. And so patients would be demotivated and not want to go home. So I had to change every single thing in the hospital. I had to change the admissions. I had to change PT. PT didn't want patients to go home. They wanted them to stay for a week. So again, I got a brand new PT who didn't know any better.
You're probably getting resistance every step of the way.
Every step of the way.
Every step of the way.
So I had to change every single solitary block in the hospital. But then after a couple of years of, and by the way, there was no nurse, it was me. So I would operate all day, and then I would go up to the floor at 6 o'clock and sit there from 6 until 10, making sure they got their IV pulled, making sure they were up, making sure PT came, and doing all that stuff.
And
so
if everybody's like, why is Dr. Berger up here?
Right.
Sure.
So, but then after a while, it really caught on, and patients started doing great and started going home. And then after a while, I was the outpatient guy. So a patient would come in and say, well, I'm going to stay overnight. You're Dr. Berger's patient. You're going home. What do you mean you're staying overnight?
So
that's crazy.
It became the expectation.
It became the expectation for everything. So I started doing more and more. And then I did the same thing with knees. We started 2 years later. I started doing unis, and then started doing unis outpatient. Then I worked with Zimmer to develop a whole bunch of minimally invasive instruments for knees. And then started doing knee surgery. And again, the same thing. We had a little difference between hips and knees. Knees hurt a little more, needed a little bit more medication. So we changed things around a little bit. And then started doing outpatient knees. So my first outpatient hip was in 2001, 25 years ago. And my first outpatient knee was 2000. My first outpatient uni was 2002. Outpatient total knee was 2003. Since then, I've just finished doing my 20,000th outpatient joint.
That's spectacular.